The first hospital in the American colonies was a place most people desperately avoided. When Benjamin Franklin helped charter Pennsylvania Hospital in 1751, hospitals were not symbols of healing. They were institutions tied to poverty, abandonment, and treatments that often killed faster than the diseases themselves. Admission required letters of recommendation. Wards ran more like poorhouses than clinics. The system that created America's first hospitals was never primarily about medicine. It was about managing the people that growing cities did not know what to do with. It all started in the most unlikely place, the home. Inside most American homes of the 18th century, illness was a matter for the family, not for strangers. The kitchen and the bedroom became makeshift sick rooms, with care led almost entirely by women. They turned to handwritten receipt books, part recipe collection, and part medical manual, passed down through generations. These books, their pages crowded with cures for coughs, poultices for burns, and cordials for fever, were as familiar as the family Bible. Remedies might call for pennyroyal water, a spoonful of cherry cordial, or a plaster mixed and warmed on the hearth. Each entry was a memory of pain survived, or a neighbor's advice written in careful script between instructions for pickling or baking. This was a world where the line between medicine and daily life blurred. A salve for sore breasts, made from herbs and oil, might be prepared alongside supper. Cough syrups were simmered from licorice root, sugar candy, and distilled waters, ready for a restless night. The work fell to mothers, daughters, and servants, who measured, stirred, and watched over the sick through long evenings. Physicians were rarely called unless illness grew dire or the family could afford a visit. Most healing relied on trust and tradition, the memory of what had worked before, and the hope that nature would do the rest. Hospitals, if mentioned at all, were whispered about with dread. They stood as places of last resort for those without kin, marked by a stigma that lingered in every household. Most families clung to the idea that true care happened at home, shaped by love, necessity, and the quiet authority of women's hands. This domestic world of healing set the stage for the institutions that would one day claim to replace it. In 1751, a petition bearing the signatures of Benjamin Franklin and Dr. Thomas Bond landed before the Pennsylvania Assembly. Their proposal called for a hospital not as a business, but as a civic duty, a place to care for the sick poor and the lunatics who wandered Philadelphia's growing streets. The language of the charter was deliberate. It promised care free of charge for those without means, and described the hospital as a charitable institution, funded by subscriptions and donations, rather than by profit or private ownership. The Assembly's approval came with a condition. The founders had to raise matching funds from the public. Franklin's subscription drive quickly exceeded the target, drawing support from merchants and craftsmen who saw the hospital as a public good, not a commercial venture. The Pennsylvania Hospital's charter set a precedent. Its board of managers, a group of elite donors and civic leaders, would govern the institution, blending Enlightenment ideals of compassion with the practical needs of a city under strain. The hospital's cornerstone, laid in 1755, bore the motto, "Take care of him, and I will repay thee," echoing the rhetoric of charity that justified its existence. 2 decades later, New York followed suit. In 1771, Dr. Samuel Bard and a group of city leaders petitioned for a charter to establish New York Hospital. Their language, too, emphasized public welfare over private gain, aiming to serve the indigent and the sick in a rapidly expanding port city. The hospital would be managed by trustees, funded by donations, and positioned as a bulwark against the dangers of unchecked urban growth. These charters did more than create buildings. They set the blueprint for a new kind of institution. Hospitals were to be civic projects, designed for those excluded from family care, and governed by rules that reflected both compassion and social order. The leap from home remedies to organized charity was not only medical, but ideological, shaping the very idea of what a hospital could be in America. Crowded alleys and narrow streets became breeding grounds for disease, as Philadelphia and New York swelled with newcomers in the late 18th and early 19th centuries. Between 1790 and 1800, Philadelphia's population climbed by 40%, while New York soared by 83%, numbers that outpaced every other city in the young republic. 7 or more people often shared a single household, and entire neighborhoods pressed up against the docks, crammed with immigrants and laborers. In these conditions, illness spread with alarming speed. The 1793 yellow fever epidemic in Philadelphia brought the city to a standstill. Nearly 5,000 people died in just a few months. About 1 in 10 residents. Homes overflowed with the sick, and city officials struggled to keep up with the mounting deaths. Makeshift hospitals sprang up in abandoned mansions and public buildings, but there were never enough beds or trained caregivers. Families who could afford to flee left the city behind. Those who stayed watched as neighbors vanished overnight. Newspapers reported 100 deaths a day at the epidemic's peak, and the usual rhythms of city life collapsed under the pressure. Cholera followed in waves, striking New York in 1832 and again in 1849 as immigration surged and the city's population ballooned. Each outbreak exposed the limits of home care and the dangers of dense urban living. City governments responded with emergency measures, quarantines, burial bans, and new boards of health, but the sheer scale of illness revealed that ad hoc charity and household remedies could not contain these crises. Epidemics forced city leaders to confront the need for permanent institutions, capable of managing not only disease, but the social upheaval that came with it. Funding a hospital in colonial America meant more than collecting spare coins or relying on a single wealthy patron. The system that took shape was built on the logic of subscriptions, a network of pledges from merchants, tradesmen, and civic leaders who agreed to contribute set amounts, often annually, in exchange for a voice in the institution's direction. Before the Pennsylvania Assembly would release public funds for the new hospital in 1751, Franklin and his allies had to prove that enough citizens stood behind the idea. Community pledges poured in, surpassing the Assembly's target and unlocking matching support. This early fundraising model gave rise to a particular kind of governance. Each subscriber, no matter how modest the donation, became part of the hospital's membership. From this pool, boards of trustees or managers were elected, typically a dozen men drawn from the city's economic and political elite. Their authority was broad. They set policies, oversaw admissions, and controlled the purse strings. The hospital's charter required them to keep detailed ledgers, manage loans, and ensure that funds were used for both construction and care. In some cases, hospitals loaned out their own capital at interest, making them not just sites of charity, but also minor engines of local credit. Religious institutions played their part as well. In cities with strong denominational communities, church collections supplemented subscriptions, especially for hospitals founded by Catholic orders or serving particular faith groups. Yet even in these cases, lay trustees, often elected by donors, held sway over daily operations and long-term planning. The result was a system where money translated directly into influence. Those who funded the beds decided who would fill them. This arrangement set the stage for the gatekeeping logic that defined early hospital care, blending philanthropy with control and embedding social hierarchies into the very structure of American medicine. Inside the walls of America's earliest hospitals, the patients were rarely the city's prosperous or well-connected. Most arrived with little more than the clothes they wore, sent by parish officers, overseers of the poor, or in the case of newcomers, by strangers who found them collapsed on the street. These institutions were built for those with nowhere else to turn, immigrants without family nearby, widows, orphans, and laborers whose wages could not stretch to a doctor's fee. Bellevue, chartered in New York as an extension of the almshouse, spelled out its duty to accept the sick poor, echoing the city's broader commitment to poor relief. The hospital's records show that many arrivals were recent immigrants, sometimes speaking little English, sometimes listed only as unknown in the admission book. One such patient, a young man from Ireland, was found shivering on a dock, feverish and alone. He was admitted not because of a medical diagnosis, but because he had no one to care for him, his fate decided by the city's promise to shelter the destitute. Early hospitals did not serve all comers. They functioned as a safety net for those excluded from family care, their doors open to the most vulnerable, while others remained outside, relying on charity or luck to survive illness. Admission to America's first hospitals was never simply a matter of need. Every bed represented a scarce resource, reserved for those who could clear a series of institutional hurdles. The process began with paperwork. A prospective patient needed a letter of recommendation, usually from a subscriber, trustee, or clergyman. This testimonial had to confirm not just illness, but also poverty and moral character. Trustees reviewed each case, weighing whether the applicant was truly deserving of charity or might be cared for elsewhere. In Pennsylvania hospitals' earliest years, bylaws required patients to prove at least a year's residency in the province and to present evidence of good behavior. New York hospitals' registers list similar requirements, including written endorsements from city officials or prominent donors. Even after meeting these criteria, admission was not guaranteed. With limited beds, sometimes fewer than 20 in the earliest years, trustees debated each application, often turning away those deemed unworthy or whose illnesses were considered untreatable or contagious. The admitting physician played a key role, both as a gatekeeper and as a judge of character. In these early systems, charity was closely guarded, and access to care was shaped as much by social standing and moral scrutiny as by medical need. Inside the earliest American hospitals, order was not just encouraged, it was enforced. Daily life followed a strict regimen, more reminiscent of a workhouse than a place of healing. Patients were separated by gender, by type of illness, and often by perceived respectability. The wards themselves reflected this logic. Medical, surgical, and psychiatric cases were kept apart, and the contagious were isolated at the farthest remove. Rules governed every hour. Bells woke patients at dawn, followed by mandatory washing, prayers, and mealtimes scheduled to the minute. Visiting hours were sharply limited, sometimes to only a few afternoons per week. Lights were extinguished at a set hour each night, regardless of the patient's condition, and silence was expected after dark. Codes of conduct posted on walls or read aloud warned against drunkenness, gambling, and unruly behavior. Patients could be expelled for breaking these rules, no matter how dire their illness. The hospital managers saw discipline as essential to both recovery and public order. These institutions were designed as much to reform and contain as to cure, serving as tools for managing the city's most vulnerable and imposing routines where chaos and need had once ruled. Inside the wards of America's first hospitals, the limits of medicine in the 18th century and the early 19th century became painfully clear. Physicians worked under the humoral theory, believing that health depended on the balance of bodily fluids. Bleeding, blistering, and purging were standard treatments, often prescribed for fevers, wounds, or even childbirth. Leeches and lancets were as common as bandages. Yet these interventions rarely helped and sometimes hastened decline. Mortality rates in early hospitals ran high. 1 in 3 patients might not survive their stay, especially during outbreaks of typhus or smallpox. Contagion spread easily in crowded wards. Before the discovery of germs, doctors and nurses moved from bed to bed without washing their hands or instruments. Surgical tools were wiped on aprons, reused for the next patient, and linens were seldom changed. Infections such as gangrene or sepsis followed even minor operations, and hospital-acquired illnesses were so frequent that many feared entering these institutions at all. The promise of care was often overshadowed by the reality of ineffective therapies, and the risk of dying not from the original illness but from what was caught inside the hospital walls. The Civil War unleashed a scale of suffering that overwhelmed every established system of care. Hundreds of thousands of wounded and sick men flooded makeshift hospitals, field tents, and city wards. Surgeons and nurses found themselves responsible for volumes of patients that dwarfed anything in peacetime. In Union hospitals alone, more than 400,000 wounded and over 1 million sick were treated between 1861 and 1865. Early in the war, a single nurse might be tasked with 20 patients or more, and a surgeon might be responsible for 100. The chaos forced a new kind of order. Dr. Jonathan Letterman's triage system, introduced in 1862, sorted the wounded by urgency, immediate surgery, delayed care, or comfort only, and it streamlined evacuation from battlefield to hospital. Dedicated ambulance corps and formalized record keeping became standard, tracking every admission and outcome. Training manuals circulated among nurses, many of whom had never worked in medicine before. Hospitals grew from scattered tents to organized pavilions, each with strict routines and clear lines of authority. In this environment, the hospital workforce became a system in itself, structured, disciplined, and essential to survival. The sheer scale of wartime care pushed American hospitals toward professionalization, laying the groundwork for reforms that would follow. By the middle of the 19th century, a new logic began to take hold inside America's hospitals. The old routines of discipline and charity, shaped by fear and necessity, started to give way under the pressure of scientific discovery. Florence Nightingale's reforms during the Crimean War in the 1850s showed that careful nursing, record-keeping, and sanitation could save lives where older methods had failed. Her approach, clean bedding, fresh air, and rigorous schedules became the foundation for modern nursing curricula, influencing hospitals across the Atlantic. At the same time, breakthroughs in medical science slowly chipped away at the dangers that haunted hospital wards. Louis Pasteur's experiments in the 1860s proved that invisible germs caused infection, not bad air or miasmas. Joseph Lister, inspired by Pasteur's work, introduced antiseptic surgery in the 1860s and the 1870s, using carbolic acid to clean wounds and instruments. Death rates from surgery dropped sharply where these methods were adopted, and the image of the hospital began to change. In 1889, the opening of Johns Hopkins Hospital in Baltimore set a new standard. Here, scientific research, medical education, and patient care were woven together under one roof. The hospital was no longer just a place of last resort. It became a center for learning, discovery, and professional training. The old associations of poverty and dread did not vanish overnight, but the authority of science was now firmly at the heart of the American hospital system. Hospitals emerged as instruments of order, not sanctuaries of healing. Their roots lie in managing the needs and fears of growing cities, not in medical certainty. Today, debates over who deserves care and how we fund it echo these origins. Our hospital system remains shaped by questions of access, trust, and vulnerability. The lines drawn centuries ago still define who waits at the door. Share your thoughts on how far we've truly come.